Hi, thanks for coming. Ooh, what day is it? What time is it? I don't even know. I think we're starting at like 2-ish. Chris Bailey, are you with us? Not yet. Okay. Caitlin, how many people did we have? How many people did we have that signed up for this thing? Like it was 120 people.
Yeah, I think you're right. Sounds about right.
All right, because I want to make sure that like we have at least a quorum.
Yeah. And it looks like Tina mentioned that the poll is closed right now. It looks like our test responses are showing up. So apologies, Tina, but we will launch that poll, relaunch that poll here. We were testing it before everyone got on.
Get out of here. Is it gone now? I'm gonna try it again.
Yeah, it's there. You just can't click on anything.
Polling. I wonder if this will work. Maybe when I relaunch it. Why do I want to go away? Oh. Now I'm nervous it's not going to work again. What if I leave the meeting and come back? What would that do, Caitlin? That'd be crazy. I'm going to do it.
So we can find out if you wanted to.
I just don't think it's going to work now. That is so annoying. Hi, everyone. I always plan to do a poll and then it never works. Oh, what is that? Poll has ended. Caitlin, do you think you can do a poll? Can anybody do a poll? Share.
Just
I
trying
really
to
wanted
mess
to know
around
where
with
everybody
it.
was. Really wanted to know where everybody was coming from. Well, you know what we'll do then? Listen, it's 2:03. It's time for the download. Thank you everybody for coming. Let's do it. Let's do a next slide. Caitlin, please. Here we go. Hi, my name is Joanne Brownstein Jarvie. I am the Senior Director of Outreach and Market Communications for MiHIN. Thank you so much for being here. This is the download, and we're going to have these monthly download webinars. The download, what I want to do in the download is sort of like the why of our business, right? The big topics, maybe some of the compliance topics, maybe some of the workflow topics and the interoperability topics, the sort of like, why do we exist? How can we help you? Broad. And then next week and every month will be the solutions that MiHIN has put in place to support those sort of larger questions, the why. So we have a bits and bytes coming up next week. You'll get an invite to that. And it will, what I plan to do is delve a little deeper into the solution side of this larger conversation. I was going to do a poll and it never works. And I don't know why, but it worked. And then you guys came here and then it didn't work. So if everybody could just leave and come back. No, I'm just kidding. Don't leave. Stay here with me. But I would love to know where you're from. Tell us in the chat where you're from. Tell us what you'd like to find out today. Tell us like what stakeholder group you represent. Tell us about your favorite, the ideal date. No, you don't have to tell us that. Everybody knows how to go through these WebExes. I hope you know how to participate in the chat, and I hope that you will. Caitlin, will you keep watching out for the chat for me? Also, this is my meeting, and we interrupt in my meetings. And I take it as a sign that you are passionate and must get your answers, the questions you have answered. So if you want to interrupt me, I think you should, and I will appreciate it. Okay, next slide. Who's MiHIN? MiHIN is the state designated entity for data sharing in Michigan. There are a lot of words on this slide, but I think what you need to take away is this. You don't think a lot about the streets that you drive on or the pipes that that bring you your water. And that's because when they're doing a good job, they should be invisible. We don't really want you, to talk so much about us. We want to be there to support you. We want to be there in the background. We are the digital infrastructure that has been invested in by stakeholder groups, including the state of Michigan, including all of the hospitals and POs that work with us, the community-based organizations that are just starting to line up, the pharmacies, the payers, and you can see here our network. But we exist to serve you. We exist to deliver for you, and you have me to continue to engage with around this. MiHIN is a nonprofit. We do not provide healthcare services. We don't produce our own healthcare data, and we do not intend to compete in the marketplace with any of our stakeholders. I want to thank you so much for being here with us today. Next, does anybody have questions about this slide? Not necessarily about MiHIN, but about what you see here. Don't forget, you can unmute, you can interrupt, you can put anything in the chat. We are monitoring your every move. Also, this is being recorded. Great. So moving on, next slide, please. Oh, here we go. Just to rub me the wrong way. Listen, I was going to do a poll. It won't let me do a poll. The poll had all of these questions. I'm just dying to, and then the poll was going to show you where we were all from. And it was going to show our speakers where you were from. So they could be, speaking directly to their good audiences, but it didn't work. But I see that everybody has taken the opportunity to introduce themselves. Thank you in the chat. It's awesome. And I really appreciate it. Chris, you're not going to be able to look at the chat, but you might take a look at it now. Look, we're already through that. Joanne Jarvie, if you need me, you can write me, call me. I am, again, the Director of Outreach and Market Communications. And today, for the download, we are going to be learning about health innovations from Chris Bailey and from a few of our clients and stakeholders and the people that we mean to serve deeply. Next slide. Let me introduce you to... Oh, that's beautiful. Look at that animation. Chris Bailey, our Director of Consumer Health Strategy. Woohoo! And we have guests, you guys. This is big for the download. We have 107 people. Thank you so much for coming. I hope you learn. I hope you engage. If you don't, write me later. It's cool. Tell me what you hated. We are having Lee Marana. Thank you, Lee, from Upper Peninsula Health Group. we are hosting Sharon from the Physicians Alliance and Jeff from Access Health. Thank you so much for being here and for, for helping Chris sort of school us today. Chris, I am going to hand this over to you, and unless I have questions, in which case I will interrupt you.
Please do.
Thanks.
Thanks, Joanne. Thanks, Joanne. And thanks everyone for joining. Hopefully I don't have a Great Dane that starts barking. So apologies in advance if that happens. Thank you for joining. This is one of the slides I always include. Again, I'm not sure I'm here to school anybody, but just share some of the things that we're up against and what we're working on. So the innovations is really about trying to figure out how clinicians and technologists communicate better to create better products and experiences for both the clinicians delivering care and the patients getting the care. And so when we think about, those interactions, oftentimes the technologists know what they can do, what they can build, what's possible. And oftentimes the clinicians are so busy with work, there's either a perceived technology barrier or a real technology barrier. And I think only when those two come together and start working together and communicating, can we sort out where the real and perceived barriers are and start working on solutions. And so that's essentially what this conversation is going to be about and where that started. But it starts with an important premise. That premise is, I'll read it out for those who aren't watching. Advancement in health technology and care alone are unlikely to optimally improve health and related outcomes unless both technology and clinical workflows, both together, people and technology and process, support improved patient health literacy and convenient access to care. And what that's saying is we can put all kinds of investment into buildings and medical devices and parking lots and cafeterias and all these things. But if we can't get patients to understand their chronic conditions and be able to speak that language and be able to communicate, nor do we give them convenient access to care, we don't really believe we're going to optimally improve healthcare, because without those two things, optimal healthcare, I think, is a non-starter. Next slide, please. So this is, I think, really the patient dilemma. There's been a lot of new technology during the COVID pandemic, and now as hopefully we're starting to ease out in some degree, we've found ways to swap that in-person office visit with a video feed. But that doesn't really solve the problem. The video feed itself doesn't solve the problem. What solves the problem, we believe, is fixing this patient dilemma. And I'll kind of talk about in later slides what potentially that optimal solution looks like. But this is where patients start. They start in a place where if they've got health questions, they did something isn't feeling right, some condition is getting worse, they need to be able to get treated, triaged, or navigated. And without the ability to have easy access, without the ability to have optionality and making things easy, very similar to Amazon, right? You all remember the days when you wanted to order a shirt, you had to check in a catalog and call and see if they had your size, color, and et cetera. Well, now all that optionality is built into a digital experience that allows you to quickly look something up, select it, and make your color, size, et cetera choice, and click send, and it's delivered. That type of experience should be available to patients when they're trying to figure out if the injury on their foot is worth going to urgent care or worth waiting on hold to talk to a doctor. So this is something both patients get, and I believe care teams get too, provider practices. They understand this as well. And so what we're trying to do in these innovations is figure out how to collectively work together to improve them. But next slide, please. But that's not easy, because we have some patient literacy hurdles we have to overcome, right? And so these are some of the highlights that we've talked about in the past. And in a study of 500 cardiac patients, nearly 60% of the patients had some sort of misunderstanding about the purpose, frequency, or dosage instructions from their medications. That's a problem. if they don't have tools, they don't have a place to go and ask these questions, or they have a perceived barrier, it's going to take me 3 calls and 30 minutes to wait on hold. They're not going to do it because they're busy, and it's going to get to a point where they're going to have to, maybe it gets to so worse that they have to go in an emergent reason. 51% of patients report they don't have clear understanding of the next steps after an appointment, so on and so forth. 36% of patients only recalled 36% of information without a prompt after a visit. We know that we've experienced that as patients too, I'm sure. Next slide. So when we look at things patients need to be successful, they need to be able to have access to their healthcare services. They need to be able to analyze risks and benefits. If I have something wrong with some condition that I'm living with, it's really incumbent on the patient to make the decision, is this serious enough to go in or sit on hold for 30 minutes to get an appointment? When we should just have a way where a patient could very quickly digitally communicate that information to a care team and sit back and wait for a thoughtful response. Calculating medication dosages. I was doing some work with testing one of the CareConvene CCDs, and I saw someone, I don't know if they should be inactive, but 36 meds. I would think after 3 or 4, it'd become very difficult to remember when to take them or how much to take. So everything from interpreting test results or locating health information. I think those are all things that these pilots are trying to figure out and address. Next slide, please. I'm trying to go through this pretty quick because I really want to hear from Lee, Jeff, and Sharon. And so where have we been? Digital isn't new, but I think we still really haven't. We're not anywhere near a mature industry. There was basic website type of visits with the Amwells and the MD Lives. The iPhone, remember, was 2008, so we probably didn't see much in the sense in the apps until probably after 2012. CareConvene started in 15, 16, and there was a period there where providers didn't think virtual was a good experience, and payers weren't paying for it. And then we had COVID. So COVID forced us all to do that. But what we found from COVID is the telehealth, the virtual experience, wasn't one in which patients could initiate it. It was just the swap out of a video camera from an in-person visit. So it really didn't provide any new substantial consumerism outside of making it easier so I don't have to drive in, which, don't get me wrong, was a huge benefit, but it didn't get us to where we need to be. And in 2021, we saw consumer access, the law that mandated payers open up their claims so that patients could download information. This provides applications like a CareConvene and other apps to be able to pull health information down, which then feeds patient with a longitudinal health history of their medications, their visits, et cetera. We're just starting that. We as an industry still need to figure out how we're going to make best use of that information, both for the patient and for the clinician who's treating them. And those are strategies we're working on at MiHIN and CareConvene. Conditions of participation, that just means that all hospitals have to send admission, discharge, transfer notifications, which is very helpful in that last mile of care. And so we've made progress, but I'll show you where I think we need to go and where we're all working towards. Next slide, please. So HIMSS has a lot of maturity models. When I and a few others were thinking about the maturity model of virtual health, they didn't have one. And I'm not sure what it looks like today, but this is where, we think of maturity in digital health. We had the pre-COVID, everything was, largely non-HIPAA, a lot of texting going on still. And it was just early adopters, people who thought the technology was cool and wanted to try something new, or for certain specific use cases. Then during COVID-19, it became this reactive, defensive, we're going to put this in because there's no other way. And so those were really practice-initiated visits. Let's send a link to the patient during their visit time. They still have to make the phone call, schedule an appointment, but when the appointment comes, we'll send them a link. Huge progress, but I don't think there was a lot of progress for consumerism, which if we want patients to be active partners in their care, there has to be some consumerism involved. Where I believe it's going is where we're moving to patients here are coordinating. There's a strong loyalty bond between the patient and their care team. The patient can go right to their care team, and anyone in the care team can respond to that question as a treatment, a triage, or navigate them to the next place in health. And so it creates a digital front door, a digital practice for that provider and patient. And then obviously clinical integration, where we're doing remote patient monitoring, we're bringing ADTs in. And then the ultimate is where consumers have some autonomy, right? Instead of their health information split into 5 EHRs and 3 payers and 3 remote patient monitoring sites, it can all be consolidated in one place so that information can tell a story, a longitudinal story of their care. And once that happens, there will be tools will mature to make that information valuable to the patient. Next slide, please. This is where we think the practices need to be in not only a patient-centered medical home, but a patient-centered digital practice where patients can initiate care. There's patient self-maintenance where they can report symptoms. They can collect device information. They can have a personal health record. They can journalize certain information so that when they see their provider, that information is available for both of them to review, as well as practice-initiated engagement screening. Whether you're doing SDOH, Jeff will talk about some of the stuff they're going to do with SDOH. Discharge, Sharon can talk about some of the things they're doing with ADTs and things, and certainly Lee will talk about remote patient monitoring. Next slide, please. This really was a slide I put together to kind of explain some of the challenges with remote patient monitoring, right? It's not as easy as just giving a patient a device. There's a lot of complexity and barriers, but as I started thinking about it, this really represents a lot of the innovation challenges. And you might look at this and say, well, you're missing stuff, and we probably are. But when we think about that first mountain we have to get over, it's really, what is the hypothesis that the project is trying to solve? What are we actually trying to do? Is always the most important question you start with. Are we trying to improve reduced readmissions by doing better transitions of care? Are we trying to help patients understand their objective and subjective symptoms using symptom assessments and remote patient monitoring devices? If so, then we need to figure out how to get patients to qualify, who's a good patient to participate, things like that, keeping compliance. And then once we get all this information, how do we share that out to a clinical team and distinguish between data versus information? And we can send thousands of data points for remote patient monitoring, but that's not very helpful to a practice. We want clinical, the what, how, and when for the clinical data. And then at some point, when we get enough of this data, we want to be able to look back and see, how are we using that? How is that supporting care? The longitudinal relevance of all of this RPM data, of all of these symptoms, of all of these SDOHs that have happened in correlation with diagnoses and disease states. So those are 3 of the challenges that we're always dealing with these innovation projects. Next slide, please. So how do we get this started, right? Because every practice has a million things to do. They have quality incentives to hit. They have RVUs to hit. We have this thing called COVID it's constraining all the things we do. But there are incentives out there, and there always have been a number of incentives that hospitals and physician offices, et cetera, could participate in. And this is an example of a lot of the stuff that Blue Cross Blue Shield does. They are really leaders in this space and thoughtful about how they're trying to build these incentives. But there was something else needed, right? This is all stuff that's been using. How do we really leverage the clinician's experience to test a hypothesis? And we can jump to the next slide. And with that, there was some innovation dollars where the Blue Cross really recognized the value of clinical input. And if we could have the clinician and the technologist communicate better, maybe we could come up with better workflows, technology-enabled workflows that help with real-time ADT delivery, with gaps in care reminders, things like that. So patient engagement. And so all of those things that we're trying to do are a result of trying to get those clinicians and technologists to work together. If you're not able to view, there's a line here. One of the toughest things about delivering healthcare value is understanding how to transform data and leverage health information to better engage patients and support clinicians. And so MiHIN are trying to do that every day and figure out how we can do that better, transform that information, all of the pipes that Joanne talked about with data. How do we make that more available and usable? Next slide.
Wait, really quick. Let's just pause here, Chris. This is a lot. You are amazing. How's it going? You guys, everyone, how's it going? Does anybody have questions up until this point? Any concerns, anything that you need that you can do to help guide Chris and his guests to make sure that they're, giving you what you need for your precious time here? If so, don't forget to speak up, please.
Absolutely. No, yeah. Stop me, interrupt me. I'm happy to jump in. I think it'll be a lot more valuable to hear after I sort of set this program up. Hear from Lee, Jeff, and Sharon. But so kind of a high level, some of the things that we've worked on: advanced transitions of care to reduce readmissions. There's been some work with postpartum depression screening, remote patient monitoring. These are all things that are using the technology not only to use digital workflows that help patients, help providers be more efficient. And that's really, at the end of the day, we want convenience for patients, but not at the cost of provider workflows. We want convenience so that it helps them partner with providers and clinicians better to make their workflow easier. And so these are some examples of that. Let's jump to the next slide. I think we're really close to getting to, here we are, good. So Joanne introduced Lee, Sharon, and Jeff. I've had the opportunity to work with all three of these and a number of others out there who might be listening. It's really been the highlight of my career, to be honest with you, to be able to work with these folks because they're passionate, they're optimistic, and like many of you, really trying to solve some of these problems that we all see are in plain sight and we want to grab and fix, but we just haven't had the time, the dollars, or the collaboration to really do it. And so I'm going to turn it over to each one of them, have them talk a little bit about their project, maybe 5 to 7 minutes, and then just open it up for questions and see what people, what their interests are. So Lee, you're first up. Do you want to just give a quick intro? I'll leave this on here so people can read this while we're doing these deeper introductions.
Sure. Hi, everyone. Thanks, Chris, for the intro, and Joanne. My name is Lee Marana. I'm the manager of the Health Information Exchange and Informatics here in the Upper Peninsula of Michigan. So we work closely with Upper Peninsula Health Group, which is a provider organization for the whole UP, and along with the Health Information Exchange and in collaboration with MiHIN out of Marquette, Michigan. So we're working on this pilot in conjunction with UP Health Group, like I said, which is the PO for the UP. We're working with Dickinson Oncology and Hematology in Iron Mountain, Michigan, home of Steve Mariucci and Tom Izzo for you NFL and Michigan State basketball fans out there, with a pilot with telehealth and remote patient monitoring devices. So we have deployed Garmin smartwatches and Wi-Fi weight scales to most of the patients. And we worked with CareConvene to integrate the auto range values from those RPM devices as notifications, just like ADTs. So care managers and providers can be proactive instead of reactive in healthcare, which is awesome. to look for any anomalies with those vitals and any other information from those devices. So, such as weight, respiratory rate, oxygen, heart rate as well. So, and then the care team can also receive HIE, MiHIN ADT alerts, discharge summaries, and also push custom questionnaires within the Care Convene telehealth platform as well. So they can actually follow up with patients for care coordination purposes. We're really trying to utilize the patient engagement tools and techniques, right, to comfort the patient, especially these oncology patients. They're going through a hard time physically and mentally, you know, a lot with radiation and chemo. So it's nice that they're always connected with the care team at all times via the telehealth app, which we're using Care Convene, and along with trying to reduce readmissions with the close patient and caregiver relationships. So like I said, so the providers have the ability to review real-time admission, discharge, and transfer alerts, discharge summaries, which CCDA format, and then auto-range values from the Garmin RPM devices, like I talked about, and then the custom questionnaires, if there's any auto-range values within those questionnaires that are custom to the practice, they'll also get those patient notifications as well. And then the caregivers actually have the ability to initiate a video visit from that, from those notifications, and even a text to visit option. So the patient doesn't even have to download the app through the App Store as well. So a couple other features include outreach campaigns where the caregivers can identify a patient-specific population and really blast text messages that are linked to a secure questionnaire and get feedback from those patients, those selected specific patients. I see this being very beneficial in the future as well, with the integration of clinical decision support and, you know, targeting specific populations if they're due for tests or appointments or anything else. The patients also have the ability within the Care Convene app to download their own health information, which is crucial, within their own PHR, personal health record, and Care Convene, to be an advocate for their own health, which aligns obviously with the 21st Century Cures Act. So far it's been a pleasure to work with, you know, all stakeholders involved, Chris and Care Convene, Garmin, and the oncology practice. So we're looking forward to all the statistics and research and studies and presenting those in the future.
Thanks, Lee. Before we jump to Sharon, I'll just say, you know, one of the things that as Lee is describing this, it sounds very prescriptive, and a good chunk of it was, but I think what we realize is all those unknowns when we try and do something new. And so they've been great partners to flex and rethink how data should come in, how often it should come in, what format it should come in. And so those are a lot of things that, you know, we all deal with when we're working on these. And sometimes it doesn't go in the direction you thought it would, but through working together, it goes into the direction that needs to go. So thank you, Lee, for sharing what you're working on in the Upper Peninsula. Sharon.
Thanks, Chris. So kind of just to build on what Lee was saying, so my name is Sharon Craddich. I'm from the Physician Alliance. I'm the Director of Quality and Utilization, and we've actually worked with Chris on several pilots. We have a current pilot going that's very exciting for us. We're using Care Convene. So we've used it for several years with our nurses that work for our physician organization. But what we've done with this pilot, we're actually putting all of our practices, all of our PCP practices on Care Convene for their ADTs. And also for some of those practices, we'll be using it for telehealth as well. But we have a vision for this. And to Lee's point, all of those features, you know, we're using the outreach campaigns and we're looking at those. But what we really want to do with this is take Care Convene. How can we connect our our care teams. So that's our PCPs, our specialists. We have PO panel managers, and how can we really build a care team to support that patient and to support those effective transitions of care. So when that patient comes out of the hospital, you know, do we have the ability to communicate? And the answer to that is yes. So there's a feature in Care Convene where we can actually communicate with anybody who has access to that ADT to determine who will take lead on that patient, to make sure that patient is getting that outreach after discharge, that 7 or 14-day follow-up, and you know, also any other needs that need to be communicated. So who is the best place, or where is the best place for that patient to go? And what we have found with this is the original premise of this pilot was to get that clinical discharge into the hands of the PCP so that they could do those med reconciliations and have that information right at their hands. Well, what Chris has been able to help us do is to get those CCDAs, to make sure that we have the current visit CCDAs, so that anybody who can manage that patient using Care Convene, whether it's on your phone, on your computer, you have all the information you need to initiate that transition of care. So it's been really interesting for us to be able to do some of that work as we work on projects with Blue Cross. We have Project Impact, where we're working with our heart failure patients, and really to be able to, you know, can we get those patients to the cardiologists if we need to? And so our vision for where we would like to go with this, and like I said, working with Chris and working with Care Convene, it's been it's been a really good experience, and it's been really helpful to us to see all these additional features that we can use, like I said, like the campaigns, the outreach campaigns, to get some of that transition of care data, because for some of these projects we work on, we have to report out on, do they have a follow-up visit? Do you have any needs? Do you understand your discharge? And that's all important pieces of information so that we know who we have to outreach to. So if you had a patient who said they didn't understand their discharge instructions, we would really want to make that a priority and make sure we connect those patients back, you know, one with us for a phone call to them, but then also back to their PCP or their specialist to get that information. So as we start to evolve in this process, you know, with this transition of care, the vision for this is that then they can also use that text to visit to be able to turn that into a telehealth visit. It's just you know, the opportunities are kind of endless here. And it could be doing SDOH screening. Do we have the ability to meet some of those needs? Because you know, that research has shown that meeting those SDOH needs can, one, support those patients, but two, decrease cost of care, improve our 30-day readmission rate, and you know, we're finding all of that to be connected. So when we're looking at transitions of care, we're really looking at how to build that whole care team and how to connect that care team for, you know, for the good of the patient. So we've had a lot of success. You know, I appreciate being here today and being able to share our story and all of the success we've had working with you know, working with Care Convene. We look forward to having all of our practices on board. And the next step to that is to bring the specialist on board, which is going to be a pretty big job because we have a lot of them. But you know, the challenge is going to be worth the reward in the end. So thank you, Chris, and we appreciate it.
Yeah, thank you, Sharon. Real quick before we jump to Jeff, there's a couple questions in there. There's a question from Nate about a nonprofit, what's in production in Care Convene. So there's we can send information out with this tool. I'm a co-founder of Care Convene, and so most of the products here are things that I experienced in my previous roles working for large systems like Spectrum, Ascension, Trinity, and looking forward to partner and create avenues where we can sort of solve some of these problems. MiHIN and the innovations are agnostic to vendors. The challenge is getting the vendors to participate and do the work, the hard work of innovating. And so, although I am, full disclosure, a co-founder of Care Convene and I work for MiHIN, these programs are agnostic. They're available for anyone who wants to partner. I think there's one other question in there. I think that got it. I'll keep looking and scrolling, but I'll see if there's any more in the web.
Teresa has a question specifically about Find Help. I have a part answer. Do you have an answer, Chris?
I do not have an answer.
Okay. So Teresa, this is not going to answer your full question because you're going to have questions after this, but Find Help has committed to MiHIN in a partnership to work on interoperable referrals. So we are just starting to really get down into the business of getting information to be interoperable between systems, and Find Help is our first vendor that's committed to that in the SDOH space. So soon enough here, I'm sure there will be a direct messaging conversation or some type of conversation between Care Convene through MiHIN with Find Help.
Thanks, Joanne. And on that note, that's a nice transition to Jeff Fortenbacher, Executive Director at Access Health. Jeff.
So, Chris, thanks for inviting me to this. I again, as you guys talk, there's just a lot of things that are running through my head, but let me kind of just take a step back. And Access Health is, definitely working in the same space in a sense that everybody else is here, or at least the last two presenters here. But our focus actually is maybe a little bit more, I would say, upstream in a sense. And it sounds like, again, the presentations we're really looking at some of the more acute individuals or people who have been hospitalized, people who have kind of a lot of acute cares. Access Health is looking at this from more of a couple different ways. One is, I guess, let me explain who we are as a program. Our program has a couple areas that it works in, but the original thing that we've been working on for 22 years is we're a community-based health coverage program. Not insurance, but pretty darn close in a sense. We aren't governed under the insurance umbrella or diffs, but we really focus on partnering with both the health system and the physicians in our practices to really identify and work with individuals who do not have health coverage. They're working, again, pretty much all of them are working, because if not, they would be on Medicaid. But those individuals that are, again, lower income, working uninsured, and some of our basic premises with them has been, one is, and again, very core to what Care of Convene is doing, is really getting and teaching the person how to manage their illness versus the illness managing them. So really, again, getting information to them, giving support to them so that they become more in kind of control and more knowledgeable about the things that they need to do to live and be healthier, and also how they can be more productive and live with their conditions that they have. What we found on this too is that one of the core areas that you have to have in this is that patient, what I call activation or engagement. And so part of our program really, it starts right up front, and that we really look at, and as we meet with the person, we kind of set an expectation that you as a member need to be an active participant in your healthcare. We're here to support you, and again, give you the information and really teach you how to navigate the healthcare delivery system and use it to your, like I said, your advantage or to your optimal, to optimize your outcomes. And so Care Convene is going to become, and is that kind of that tool that starts to have us start to be better communicators and more effective communicators with the members. I've always kind of looked at this as the point is that, again, even with technology, we can have the best products out there and the best products can be done, but until that person actively chooses to use that product or use that tool, it doesn't matter what we do. And so that'll kind of segue into two. We understand that the SDOHs and the social determinants of health, or social influencers of health, significantly impact, in a sense, a person's ability to take focus on their health. I mean, they have all this other type of stuff, and especially as you start to move and work with the lower income population, a lot of times it's crisis to crisis. So, I mean, again, if you're being evicted from your house or you're getting kicked out and that type of stuff, and you're going back and saying, well, did you eat your 3 vegetables today? Did you test this? Did you do this? All that stuff goes out the window. And so we've even moved that to a point of where we specifically, and speaking to the place-based area under the Muskegon Shire, we've, based on the engagement, based on getting people to focus on their health, picked a general area that has been in a distressed community. That community has been kind of pretty distressed for probably the last 40 some years. Not a lot of kind of growth or movement from the community in kind of improving the conditions there. So we took a different approach, and we actually went to them and said, instead of a bunch of white, in a sense, white people, but people from the outside, social workers and that type of stuff coming in going, hey, we got this great program for you. We're going to do this, this, and this. And then maybe when the funding goes back 3 or 4 years later, it goes away, it goes away too. And so we kind of went in and said, you know what, we want to work with you, but we also want you guys and you as individuals and a community to start to identify and look at what things are going on in your community that you like, maybe what certain things that you don't like, and things that you'd like to be changed or like to change, and how can we help with that? And we would support, again, if you choose to, in a sense. We aren't going to say you have to work with us. And so what that did is it really led to, again, something that technology kind of has done, in a sense, is that it's really had us move to a term that I heard back when I was in college many years ago, but becoming more of a cocoon society. You don't have to leave your house to do anything anymore. So it really led to a lot of more social isolation and lack of interaction, especially even on the neighborhood or neighbor basis, and really kind of broke down a lot of our kind of home areas and neighborhoods in that. So, I mean, we went back and they actually started to do and said, yes, we would like to really take a look at that. So they did some planning. They also did some survey work type of stuff with the community. And to kind of move it along is that it started out with like one neighborhood association. We're up to 7 neighborhood associations now. There's about 7, they have a council, a neighborhood council now that then is becoming, again, more of a convener and listening to the people's voices, but it's starting to activate that engagement. And now we're starting to come in and look at, again, how we can start to deploy technology and support around health issues, because health is definitely one of the issues. The other issue that, again, as a part of the engagement that we found is that when you go into some of these, the distressed communities, there's not a lot of trust of the healthcare delivery system. And so therefore you're asking, again, them to use technology and that type of stuff that is somewhat more invasive, because you are starting to ask them about not just about what their blood pressure is or what their, that type of stuff, but you're starting to ask them more intimate questions around what other things are going on in their life. And they aren't always open to sharing that with you. And so, again, understanding and working with and developing that relationship is going to be key and instrumental. And that's kind of, like I said, the area that we're going to is really looking at how do we now then, as we've built our relationship and even furthered our relationship with the population, about how can we actually deploy technology so that we can actually make and have them be able to live healthier lives.
Right. Thanks, Jeff. Any questions for Jeff on that? What he's doing with the Shire and community-based organizations? Thank you, Jeff. There's some great questions in the Slack, and Amy, I'll just your question is very good. How is CareConvene different? Differentiating or using eHealth Exchange or Care Quality, and I may be wrong. I'm not an expert on those. Other than I would say that those are very useful tools for providers searching out records and connecting longitudinal health information to make an important story about a patient. CareConvene is looking at the other way, and that is, how do we empower the patient to have all the information that they actually own? My 5 different instances of health records in 5 different EHRs, my information in 3 different payers, my information on Garmin, Fitbit, and Withings. Why is that spread to 3 different areas? And great, if I think it's wonderful that the organizations have gotten together to say, how do we connect all that information? But I want it in my system because I want it to help me give insights to my care. If I'm not an educated consumer, I'm really not much use to the clinical interaction of the care team. I have to continue to rely on clinicians to do everything. And so kind of part of that key takeaway is we're really pushing towards a consumer mentality. Because if you're a consumer, you're making active decisions on what is value. And that's really, I've been in so many meetings at large health systems that, would call that blasphemy to say a patient is a consumer. But I think there's an aspect of importance there because if you're a consumer, you're making value judgments on what you want. And I think that's important. There's a couple other takeaways here. This stuff probably it's all very obvious.
Hey, Chris, Sharon had a question here just on with regards
okay.
to how we coordinate with the CBOs. Is that something you'd like me to answer or not?
Oh, please do. Yeah, I was just going to wrap up. So we've got time for questions.
So again, I think our way is really how do we actually take from the patient and push that information up to the physicians and up to the practices. The other part is how do we and how is our community moving forward with organizing the CBOs so that the information that they have as it relates to maybe some SDOHs, but also intertwined in that would be medical information or medical concerns in a sense, and how does that get back to the physician? So with Chris, whatever we're undertaking, and she also asked about the consent part of it. And so as a part of our Shire work that we're doing in Muskegon is just that. We're looking at, again, we have kind of a core agencies which tend to involve or have involved the FQHCs, our Health West, United Way, and also it'll be ingrained in, or not ingrained, but incorporate 211 as a referral source and as an entity that supports or directs patients, especially as it relates to social determinants into care. Anyways, for those, we are looking at, again, getting that into the hands of our members, and then as they get referrals into the to the agencies, and the agencies can work with that individual who will have the app on their phone to be able to, one is address the and really kind of direct their own care. So it's really more supporting them and directing their own care, but that's how we plan on handling consent for this, is that empowering the patient. Again, as I started earlier here, is that a couple basic premises is that every interaction that we have with one of our members needs to be empowering. So we're really, again, teaching them how to be effective advocates for their healthcare. Again, we have a little bit different opportunity since we are the payer in a sense for some of their services, but we're also very much based on how we've rolled out the program. We're partners with them. So really, again, getting them and the information and care convene is that key component of being able to do that is allow them to be that kind of director of their care. And I think that's kind of where Chris was saying that the last part of this is kind of going, is that where the individuals has the information and has the support to really be their own advocate and start to really direct their own care.
Yeah, thanks, Jeff. Again, this was not a gimmick that started during the pandemic to try and create a business and sell some telehealth. This was 2014, and many years trying with a 10-year plan, and it was because we were tired of the status quo. Why do I have an injury on my nail and I have to go to urgent care and get an $800 bill? Things like that. So, we represent MiHIN and Care Convene. We're product agnostic. but we're hoping that there's others out there who are kind of tired of the status quo, and have interest in innovations. And whatever your product is, make sure your vendor understands the importance of clinical workflow and how you need to do your work as efficiently and effectively as possible. So that's really what we've stepped into. That's where we wanted to be. We were never create a product and sell it and walk away. It was trying to figure out how to solve these problems because we're very tired of the status quo. So if there are any other questions, I think any of us would be happy to answer it. I hope this was a valuable hour, 53 minutes.
Wait, stick around. Don't leave yet. Kate, tell us what's coming up. What else have we got for the folks here? So you just heard a lot from this Chris Bailey. You like him. You like his face. You like what he has to say. Come back to Bits and Bytes. We're going to delve in a little bit more into the CareConvene product. We're also going to introduce you to our product managers and designers around MiHIN, ADTs, CCDs, laboratory orders and results, radiology studies, transcribed documents, and pathology results, all sort of bundled into what we call message delivery. If you want to get into the details, you want to talk to these guys, these architects, these designers, they're hard to talk to, but I will help you. Come to Bits and Bytes. That's next week. We'll send this out. We're sending out an invite today. Next month, February 16th, is the next download. We're going to talk about TEFCA, I think, and CMS and some of those, some of that work, like the national work. With our head of privacy and consent, and that's going to be some really important information. And so that's all we have for now. I really love that you guys were here. I invite you to write to me and write to our team. Tell us more about what you want, and to come back every time and engage with us. And come online. What else do you have to say? We have 5 minutes. Chris, did you see that that chat from Teresa regarding advanced care plans, advanced directives, COVID plans, birth plans? MiHIN is doing use cases around this. How are we using CareConvene? How could we be using CareConvene?
That's a great question. I mean, these are things we don't have complete answers for, but we have ideas. And again, they always start around how do we make the patient and the clinician's workflow work better. One of the things that's possible, again, I would surmise if I have my patient hat on, my consumer hat on, is if I have an advanced directives and advanced care plan, I would want to have that updated somewhere on a device that I could interact with all the time. I would also like to be able to share that with other people. And so, how does a tool like CareConvene or other tools be able to tap into the AD Vault to be able to experience that? And at the same time, consent can be given, et cetera. So I think there's a lot of opportunities for that. CareConvene has a personal health record so that when you're connecting to payers to download, claims and medications and all those types of things, it's a perfect place to throw your advanced directives. And so keeping all of that together, I think, could add a lot of value to a patient-provider conversation. But nothing has been officially started there.
But we can pilot, right? Chris, we're here for innovation. We're
We
here
are
to
always up
partner.
for that. Yes, even if it kills us. Colon cancer outreach. That's a great question. Was that on there? I'm not sure. There's a lot going on with colon cancer outreach. So Kayla, we may not have enough time to talk about this, but I would love to chat with you if you have interest. But essentially, if organizations have to do colorectal screening or some kind of cancer screening, there's often many patients who need that, and they need to do that on an annual year, and that number never seems to go down. How can we make it easier to educate a patient on what their options are, and then give them simple pathways to select an option, whether it be a Cologuard or a colonoscopy, allowing them to make that choice and move forward in that workflow. So yes, there is a lot of work going on with that. can you speak about how it's be beneficial for OBGYN practice? Interesting you ask, Allie, because there is another project out there. We're working on maternal health. And so I think maternal health is an important topic. And we talk about remote patient monitoring and managing certain diseases and pregnancy related diseases. So giving patients the ability to share remote patient monitoring data, giving the ability for the patient to send in symptoms. I'm sure most first-time mothers are very nervous about symptoms. And so giving them an easy way to connect is everything we're trying to do with connectivity. So lots of opportunities in that space. PCP, definitely specialist. You think about, real quick, think about any kind of a specialist who's participating in a bundled payment. That patient gets out of surgery, whether it's a hospital or ambulatory care setting, and the patient goes home. What are they doing to give that patient tools with which to manage their surgery? A friend of mine's wife had a hysterectomy and became septic. I just wonder if she had ways to submit those symptoms in real time and know what to look for, educate her, and give her access in real time with a couple clicks of a button. Maybe she wouldn't have become septic and have to had her arm, both legs and an arm removed. Those are the kind of things that's low hanging fruit. That's easy to do, and we should have been doing it, 5 years ago as an industry. So those are the things I get passionate about and get frustrated and impatient. So there's lots of opportunity with specialists. Someone's got to do it, whether it's Care Convene or any other application. Somebody ought to be doing it. And Lee's doing a lot of that up there in with the oncology patients, giving them easy access to report symptoms. I mean, why wouldn't we make it that easy for somebody? So
let's just make something easy, you guys, please. All right, next time we're going to come back. We're going to delve into the products, and then we're going to have another download, and then all of a sudden it's going to be 2025, and it's going to be a whole new world. Thank you so much for coming. Write us, call us, give us feedback. I know you do, and it's going up the chain. I promise you. Thanks. Thank you for being here.
Yep. Thanks to all speakers.
We will be sending out the slides and the recording as well, as we always do. Thanks, Lee. Thank you, Jeff. Thank you, Sharon. Chris, that was awesome.
Pleasure. Thank you.